Welcome, Dr. Thomas.
Hi, great to be here. Thanks for having me.
So we're going to have very insightful, interesting discussion. So for the viewers, of course, welcome to India's second Metabolic Health Conference focused on metabolic therapies. And I'm Shashikant Iyengar, Metabolic Health Coach in association with D Life. So me and Anup Singh, we are the co-organizers of this Metabolic Health Conference, a scientifically packed session, so specifically focusing on the ketogenic therapies in various disorders like mental, neurological, CKD, cancers, and we are going to have very interesting. So today I welcome Thomas Weimbs, PhD from the United States of America. Welcome, Dr. Thomas.
Yeah, thank you very much.
So I'll give
Great
a
to be.
brief introduction of Dr. Thomas Weimbs is a professor at the University of California in Santa Barbara, where he directs a research lab focused on polycystic kidney disease, or popularly known as PKD. So he received his doctoral degree from the University of Cologne, Germany, and then conducted postdoctoral research at the University of California in San Francisco in 1999. He started his first independent research lab at the Lerner Research Institute at the Cleveland Clinic as assistant professor. Then he started his research on PKD after he was approached by a local family affected by PKD, who financially supported the PKD research in his newly founded lab. Their family donations still support the PKD research in Dr. Weimbs' lab today, even today. In 2005, Dr. Weimbs moved his lab back to California to join the Department of Molecular, Cellular, and Development Biology at UCSB. His laboratory studies molecular mechanism underlying polycystic kidney disease with an emphasis towards developing new therapies. Research at Dr. Weimbs' labs has led to a better understanding of PKD and led to novel method to deliver therapeutics specifically targeted towards polycystic kidneys. Some of the most recent research has led to the discovery that dietary interventions and natural metabolites strongly slow PKD progression in animal models. This led to the launch of Santa Barbara Nutrients with the goal of making these approaches available for the nutrition management of PKD and to support kidney health. So, Professor Thomas or Dr. Thomas, please tell the audience, many of them may not be knowing what exactly is PKD and is it fatal?
Yeah, absolutely. Thank you, Shashi. I should probably put up I don't know if I can share. Oh, yes, I can. Maybe I'll put up real quick my disclosure slide here just to make sure we have that out of the way. As you said, I'm a professor at the University of California at Santa Barbara, but I'm also a founder, president, and chief scientific officer of a startup company out of UCSB, Santa Barbara Nutrients, and here's some other disclosures as well. Yeah, so what is polycystic kidney disease? It's a genetic disease. It's essentially a genetically determined form of chronic kidney disease. As you're well aware, chronic kidney disease is extremely common. I think the last number I saw in the US was that it affects about 14% of the adult population in the US here. Out of that, much smaller fraction is due to genetic causes, and the most common genetic cause is autosomal dominant polycystic kidney disease. So in those patients, they typically develop chronic kidney disease, and it can be very variable. It can be much earlier onset, it can be much later onset, even within the same family. It's unclear what makes it so variable, although we have some ideas about that. And eventually, for most patients with ADPKD or autosomal dominant polycystic kidney disease, the kidney disease progresses to renal failure, at which point they need to be on dialysis and look at a kidney transplantation.
So I did have one of my uncles having PKD long back. So I was in college that time, so we never used to understand what exactly it is. Now when we see
Mm.
all this research coming, I did read about all those studies. Now we suddenly realize that yes, so it's quite a terrible disease. So what is the current treatment options for this? What is happening to these patients? How are they
Mm.
managed?
Yeah, so the current treatment is really limited to one approved drug that is approved for polycystic kidney disease. It's a drug called tolvaptan, which has been shown in clinical trials to somewhat slow the progression of polycystic kidney disease, but it does not stop it, let alone reverse it. So it's a little bit unclear who really benefits from it, by how much, but in general, the thought is that rapid progressors might slow down the disease progression by somewhat, to buy them some more time. The drawbacks of the drug, of course, is that it has drug side effects. It has toxicities, and probably the biggest problem is polyuria that is induced by through the mechanism of the drug. So these patients have to go to the bathroom very frequently, day and night, which has quite an impact on the quality of life. The drug is also very expensive. Which limits its availability worldwide. Other than that, patients are just managed for their symptoms, for blood pressure, and eventually, once kidneys fail, they'll be on dialysis and go on a kidney transplant waiting list.
So is there any way that we can detect this earlier, or is it purely that it is genetic that someone of us have, and then we might ultimately get it, or does it also develop suddenly in some? Is there any way to know it early?
Yeah, so most patients really have inherited it from one of their parents. So they would have a family history, and they would already have known about it. So in those cases, it's usually not a surprise. And the kids can be diagnosed at some point, by ultrasound, for example. But in about 15% or so of the cases, those are new mutations. So this can be as much a surprise as any form of chronic kidney disease. And sometimes people might be diagnosed much later during the course of the disease. Oftentimes, it's an incidental finding due to some, CT scan for some other reason. So it's always, if it runs in families, it's so far, oftentimes, patients have not been recommended to have their kids screened, for example, because the idea was there's nothing you can do anyway. You might as well, look at a diagnosis later on. And I think this might change because I think there are things that people can do themselves even early on, and probably even the earlier the better.
Is hypertension one of the symptom of this? Let us say someone has a family history of PKD. Person may
Right.
not realize that he may be susceptible. And if the person develops hypertension, so is it that PKD is behind this?
Mhm. Yes, yeah, for sure. Hypertension is one of the earliest symptoms in ADPKD, and that's oftentimes, when something is suspected, and then one can follow up with an ultrasound, for example, to make the diagnosis. Yeah, but for sure, almost everybody with PKD at some point has hypertension.
This hypertension, is it milder form or very intractable form? Like what you call as resistant hypertension, or how is it?
Right. Well, it is typically managed, with medication. And however, one thing we've found is that ketogenic metabolic therapy is actually very effective in treating hypertension in polycystic kidney disease. So that's not common, standard therapy at this point yet. And I hope it will be at some point soon, because you don't really want to be on antihypertensive medication forever for the rest of your life if you don't have to be.
So this PKD is different from that CKD which happens purely that I think CKD is due to some other etiology.
Yeah, so of course the main reasons, the main triggers for for CKD in general, the general population is diabetes, type 2 diabetes, and hypertension, which I kind of lump together anyway as metabolic disease. So probably, something like 2/3 at least of the cases of CKD are, due to poor metabolic health, which essentially means hyperglycemia, hyperinsulinemia, insulin resistance, and, obesity then plays a role. And those are kind of the immediate causes for most patients with chronic kidney disease that don't have a genetic predisposition. Something that we have been working on is to figure out whether there are actually triggers also in polycystic kidney disease. So it has always been thought that polycystic kidney disease just happens, based on the gene mutation, and that it's inevitable to lead to cystogenesis and progression of the disease. We don't actually think that is true anymore. We think, and that's actually based on many years worth of animal research, not only in my lab, but actually by a whole number of labs. It's very clear in mice that if you induce a gene mutation in a transgenic mouse model, for example, that essentially nothing happens for a long period of time. So for months and months, the kidneys are just fine. They don't form polycystic kidney disease. But then if you trigger a form of renal injury in these animals, and this can be, like a nephrotoxic injury, it can even be hyperglycemia, ischemia reperfusion injury. We have looked at microcrystal injury. This all leads then to rapid onset of cystogenesis and PKD disease progression, suggesting that just having the gene mutation alone is actually not enough to give you chronic kidney disease. You need to have these injury triggers, which are the same triggers that can lead to acute kidney injury and then going on to chronic kidney injury in the general population. So that's something we're very interested in pursuing, because if once you know what those triggers are, of course, that gives you the power to try to remove those triggers and try to have a disease-modifying, way of treating patients just with diet and lifestyle interventions.
Is it normal for most of us to have 1 or 2 cysts in kidney? Or
Oh,
will
yes.
will it
Right.
lead to PKD for sure? For example, I have a couple of cysts in one of my kidneys. It was shown
Right.
in one of the scans. So is it normal?
It's very common. It's, age related. Usually the older one gets, the higher the chances are to have a few cysts. They usually are benign in most of the cases, and most of the time are never discovered and don't cause any trouble. Those are called simple cysts. So essentially, almost anyone that dies of old age probably has a few simple cysts. And they're probably inconsequential for most people, except if someone is unlucky and just has a very large simple cyst that might compress some neighboring tissue, for example. But those are otherwise very common.
Anyway, I'm on a ketogenic diet. So
Yeah, they're excellent. Yeah.
so what got you interested into the ketogenic approach for PKD? Is
Yeah.
that,
So
have you conducted some study or were there studies earlier? How is it?
yeah, so we sort of stumbled on it a little bit by accident. So if you will, in an unbiased way. So we didn't say, hey, keto must be effective. Let's try it. It was completely the opposite. And this was actually a bit of a random chance observation when I had a graduate student, a PhD grad student in my lab who did a sort of an almost unsanctioned experiment that he didn't ask me to do if he could do it. And, I would probably have said no to it because I wouldn't have thought this would work. So we had, for many years, we had worked on mTOR, the role of the mTOR signaling pathway in disease progression and polycystic kidney disease. And mTOR is, controlled not only by growth factors, but also by the nutrient status of cells. And my grad student had sort of reasoned that, hey, if I feed my mice, my polycystic kidney disease mice, less food, maybe I can affect mTOR in those kidneys. Again, I wouldn't have thought this would ever work, and he just did it anyway. And one day came came with the results and said, "Hey, Thomas, I did this experiment. I put our mouse model on a low food intake regimen." And just a mild reduction in food intake, something like 23% less food than in the control ad libitum fed mice. He didn't change the quality of the food, the same rodent chow, he just gave them less food. And nothing happened to these mice, they were happy and healthy. The only thing that was different was that their polycystic kidneys did not progress, or at least not as fast. So it was a very dramatic effect. We did some studies. We published the paper and essentially said, hey, food restriction works, and we have no idea why. So this was kind of the first indication that there's something going on there. And then afterwards, we try to figure out what's actually going on, and realize that this actually has to do with the induction of the metabolic state of ketosis. Because if you put mice on a reduced food intake regimen, what you inadvertently do is you also put them into ketosis, because and that's kind of done in all the food restriction studies, caloric restriction studies. The control group is always ad libitum fed. So the mice have a mountain of food in front of them and they can eat all day, all night, as much as they want. The control group always gets a pre-weighed amount of food once a day. And that completely changes their feeding behavior. They actually eat all the food pretty much at once in an hour or two. And then for the remaining 23 hours, they are fasting, which then puts them into ketosis, after a few hours. And we found exactly that, that we have elevated BHP levels, and then we can we can more specifically induce ketosis with things like a ketogenic diet, acute fasting, and all of these interventions were highly beneficial in stopping cystic progression in those kidneys, and even partially reversing existing renal cystic disease, which was really unheard of before. So that was never on anyone's radar, that you could actually partially reverse the disease, at least in animals you could.
Very, very interesting. That means you just restricted the food to a window just once a day and 23 hours. And this food need not be necessarily low carb or something. You just gave them any food, or how was it?
Exactly, yeah. So just standard rodent chow. And rodent chow is very, very high carbohydrates. So lots of carbs in there, starches, sugars, and so on. And the trick is just to do it in a time restricted way. And we've repeated this in other rodent models. We have rat models, we have mouse models. We've also done experiments in cats. So there's actually a cat model, a feline model of polycystic kidney disease, which is probably the closest model to the human disease, because it's the same gene that's affected in the human disease in these cats. And it works just as well in any of these models. So you can either restrict the timing using the same chow, or you can use a ketogenic diet. So you change the type of food. And in this case, you don't change the timing. So you make it ad libitum. So you compare ad libitum feeding with normal rodent chow versus ad libitum with a ketogenic chow. And this works just as well. In fact, probably even a little bit better than just time-restricted feeding.
Did you feed them direct ketones, BHB?
Yeah, so that was the other experiment that I would never have thought would work. And so the idea is, okay, what is the secret ingredient, of a ketogenic diet, if you will, that actually gives you the benefit. So we tested whether we can just replicate or mimic the beneficial effects by just giving exogenous beta-hydroxybutyrate, the main ketone that is normally produced by the liver in ketosis. We can supplement it in the drinking water, or we can put it into the food, formulate the food with exogenous beta-hydroxybutyrate. This is then on top of a regular rodent chow. So we have a high carb rodent chow. We just put in beta-hydroxybutyrate, and this essentially replicated the beneficial effects of nutritional ketosis. To my surprise, again, I wouldn't have thought that that's enough. So this suggests that the BHB itself is actually has dominant effects on disease progression, chronic kidney disease progression in PKD. And that's something we're very interested in kind of nailing down, the mechanisms in the lab. So we've been working on this, for a good number of years. As I'm sure you know, BHB has many effects, many biological effects. So it's not only used as a as a fuel by cells to be burned for energy, but it's also a signaling molecule. So there's actually a receptor, a BHB receptor. It's called GPR109A. That is a a G protein coupled receptor that acts on cyclic AMP signaling. And cyclic AMP signaling was already known very well to be dysregulated in polycystic kidney disease and play a role in the progression of polycystic kidney disease. So BHB, through this particular receptor, actually inhibits cyclic AMP signaling. So that was kind of our bet was on that this receptor is involved there. So we have done a lot of studies using knockout mice that we can cross with polycystic kidney mice. And then we can test whether the beneficial effects of BHB or ketogenic diet would disappear, right? If the mice don't express that receptor anymore, and if the receptor is essential for the beneficial effects of BHB on the kidneys, you'd expect nothing to happen. And that's actually what we've seen. So it's not published yet, but we're putting the results together. So it seems pretty clear that the receptor is at least partially involved in the beneficial effects of BHB. And BHB also is, of course, a strong anti-inflammatory molecule, and inflammation is very prominent in chronic kidney disease progression in essentially all forms of chronic kidney disease, including polycystic kidney disease. So that's something we're very interested in nailing down is, which parts of the immune system are really involved in driving the disease progression, and which of these parts are then can be influenced by ketogenic metabolic therapy and by BHB in particular. So we're actually launching a research project on that, where we can also take advantage of clinical trial samples that we have access to.
So in this mouse model, did you find that it only stops the progression, or were there some reversal?
Yeah, so surprisingly, we found reversal. That's something we published back in 2019. And the reviewers of the paper, so the paper came out in Cell Metabolism in 2019, and the review we had kind of boldly stated, hey, if you put and I think in this case rats with polycystic kidney disease, we put them on a ketogenic diet, and we do this with rats that already have fully established polycystic kidney disease, you actually partially reverse the disease, and you actually improve fibrosis, you improve the cystic burden. And the reviewers didn't like that, and they said, "Whoa, that's impossible. That has never been done before, and you cannot make such bold claims." So we had to kind of tone this down and essentially, a little bit hide the fact that this is actually extremely effective. So yeah, so we already published this, whether, of course, this translates one-to-one to humans, is to be determined in long-term clinical studies. But at least that's, the observation in animal models of PKD.
What about human studies? Do we have any one of them?
Yeah, so yeah, very good question. So we had actually pretty early on had done a retrospective clinical study by kind of rationalizing that many people have polycystic kidney disease, and it's a very common disease. So there's over 600,000 people with polycystic kidney disease in the US alone. And also many people are on ketogenic diets, just for general health reasons, weight loss reasons. So we thought, okay, there's a chance that people with PKD might already be on ketogenic metabolic therapy, and let's try to find them. And this is a study that was done by Sebastian Strubel when he was in my lab, actually during COVID times, when the lab was shut down, and my postdoc Sebastian wasn't able to really do the animal experiments he was trying to do. So we said, okay, let's do a clinical study. So he actually happens to be a nephrologist, and we did the study in the COVID downtime, identified something like over 130 people with PKD that had already done ketogenic, either ketogenic diet or intermittent fasting. And we got their health records. We did interviews with those folks, with questionnaires and so on. And the data were actually really striking. So during approximately 6 months on average intervention time, there were quite some dramatic effects on improving not only metabolic health but also renal health in these patients. There was actually a statistically significant increase in kidney function as measured by EGFR, creatinine-based glomerular filtration rate. So we published this paper. And this came out a few years ago, but it's a retrospective analysis, with many caveats, self-reported outcomes. So everybody says, hey, you need a prospective randomized trial, and which we had actually already launched. And this was this randomized control trial is done with at the University of Cologne in Germany, by our long-term collaborator, Dr. Roman Müller and his team. So we had kind of planned this study together and raised funds together to do the study. And it was just published a few months ago in, I want to say, November, December last year. Came out in Cell Reports Medicine. And maybe if you like, I could share my screen here for a second and just show you the paper. Let me just scroll down here. Here we go. This is the paper that came out. Again, Roman Müller is the principal investigator, and it's really his team that did all the work and deserves all the credit. This was a randomized controlled study with 3 arms, 66 patients altogether, randomized into a ketogenic diet, a control group with no dietary change, and a water fasting group. And a relatively short term, only 3 months intervention. And the main outcomes were feasibility, safety, and efficacy. Looking at whether patients actually achieve ketosis, and many lab markers, including looking at kidney function markers. And to our surprise, there was a statistically significant improvement in kidney function. So we didn't really expect that in only 3 months of an intervention. And you can see this here on the left. This is looking at the creatinine-based EGFR numbers. So the control group had no change during the course of the intervention. Surprisingly, the ketogenic diet showed a statistically significant increase in EGFR numbers after only 3 months. That was a surprise. When we initially presented these results in a poster abstract at a kidney conference, that was actually very interesting. I got on the same day, a couple of my colleagues sent me emails saying, "Oh, that's not a surprise. Of course you will see." One person argued, "Oh, of course you will see an increase in EGFR because you're giving them less protein to eat, less meat." And the other person said, "Oh, of course you're going to see an increase because it gives them more protein to eat." So they had kind of opposite thoughts of what would be happening there. And in fact, protein was not changed in those diets here. So it's just moderate protein intake. So luckily, we also measured EGFR then afterwards by cystatin C, a different marker of kidney function that is actually independent of dietary changes. And it was the same outcome. If anything, even a stronger increase in kidney function here. So this was surprising. A lot more than expected. It's only a 3-month study, of course, so we'll have to do longer term studies, which we're actually doing right now, or through this company that I mentioned at the beginning that we launched, Santa Barbara Nutrients, where we're testing long-term outcomes of different forms of ketogenic metabolic therapy that also involve a medical food that contributes a beta-hydroxybutyrate, exogenous BHB. That's a medical food that the company makes called Ketocitra. So we've started one trial already in Tokyo at Juntendo University with Dr. Shigeo Horie. This will be a trial with 100 patients in the intervention group and 100 controls, looking at a 1-year intervention. And that's looking at ketogenic diet plus this medical food delivering exogenous ketone. Another study, fingers crossed, where we got a really good NIH grant score. So this study will hopefully soon get funded and can start at the University of Southern California, USC in Los Angeles. That's done with Dr. Nuria Pastor-Soler, a nephrologist there. And this study will look at only this medical food Ketocitra, so only the exogenous ketone compared to standard of care. So this will be a 2-year intervention in a randomized controlled study. So this will tell us whether just simply adding exogenous beta-hydroxybutyrate on top of whatever diet patients choose to have might replicate some of the beneficial effects of full-blown nutritional ketosis.
That's
And
very
in
interesting.
addition, go ahead. Yeah. Oh, I was going to say, in addition, we have about something like a dozen other clinical trials in the pipeline. Some of them are looking at different aspects of benefits. For example, we're looking at metabolic health improvements in a study with the Cleveland Clinic that we're planning, that we're, I think, close to hopefully starting soon. We're looking planning a study with Johns Hopkins University, again in ADPKD, looking at a sort of a low carb intervention, kind of a keto light version, if you will. And that's looking at using Ketocitra, the exogenous ketone product, in combination with just low carbohydrate dietary recommendations, which might be a little bit easier, on patients and more sustainable in the long term for them to do. And we have a number of other studies lined up. We're trying to look at at the kidney stone risk, for example, in a study in Vienna. That's something that we have actually found in my academic lab at UCSB to be a very potent trigger for polycystic kidney disease. And as you know, kidney stones are very common and have become more and more common and are strongly linked with metabolic disease as well. And something we had found in the lab is that these microcrystals, something like calcium oxalate, microcrystals, excuse me, that can form in kidneys and eventually go on to form kidney stones. These microcrystals can trigger new cysts to grow and essentially jumpstart polycystic kidney disease. And that's something that we're trying to inhibit also with the same medical food that delivers beta hydroxybutyrate, because it also contains citrate, which you see is the antagonist of calcium crystal formation in kidneys and can essentially improve, we hope, renal health by preventing these injurious microcrystals.
So this is very interesting, because if people do not have to change their diet from whatever they're taking, and they're able to take this BHB supplement which you have formulated, and if they're able to prevent the progress or reverse it, it can be a win. And since there are not much pharma drugs also available in this, so I don't think there'll be much of an issue. Do you face any pushback on this? The application of ketogenic diet or ketone supplement in PKD, which is a kidney disease, from the mainstream?
Absolutely, yes. I think there's a lot of pushback. And, nephrologists maybe tend to be the more conservative type of doctors, and probably for really good reasons, because there is, the kidneys, they're the frontline detoxification organs in the human body, and anything you're exposed to oftentimes, goes straight through the kidneys and impacts the kidneys. So lots of people, in the history of nephrology, I would say, have injured their kidneys, with terrible supplements and, herbal extracts and things like that, and all kinds of weird diets, that are around. And typically, nephrologists always say no to that, for good reason, because they don't want their patients to, fall for some internet scam of the latest herbal extract that actually makes their kidneys worse. So I can understand that nephrologists are wary of something that's not an FDA-approved drug. And of course, an FDA-approved drug or any regulator, in any country, a drug comes kind of with the safety net for the doctor, that if something goes wrong, it's not their fault, right? It's the FDA's fault, for approving the drug. So that makes it a little bit safer. And nobody wants to be the first to recommend something that is not approved, but also nobody wants to be the last. So I think eventually, as we get more clinical studies and publish them, I think things will change rapidly, because nobody wants to, I think, withhold a life-saving way of treating their patients from their patients. So eventually, I think the word will spread and people will be convinced. But for the time being, yeah, you're absolutely right. There's a lot of pushback, and everybody says, "Hey, where's the clinical trial, the randomized controlled clinical trial published in the New England Journal of Medicine? Show me that before I will do anything." But of course, practitioners don't realize the economics, the economy behind there, because a randomized controlled clinical trial, is extremely expensive, especially in a slowly progressive chronic disease like polycystic kidney disease. So the trials that led to the approval of the one and only drug for PKD. They involved over 1,000 patients, several years of intervention. They would probably have cost, I don't know the dollar amount, but we're talking about $100 million minimum, probably way more than that. And as a pharmaceutical company, you can make that money back later on. Once your drug is approved, you just simply charge an arm and a leg for it, and you get your money back. For a diet, or a food or medical food, you never get $100 million back, right? So you cannot sell a diet, and you cannot sell a simple supplement or medical food, that has a tiny margin there, for to ever get $100 million investment back. So these trials will never happen at the standard of a drug trial, where you have a phase 1, phase 2, phase 3 trial, and that's just not in the cards, and that this will ever be done. Unfortunately, nephrologists kind of expect that type of drug trial because that's all they're used to, and they're not used to nutritional intervention trials, because they're just different. You cannot do a placebo control because everybody knows what they're eating, right? So that's out the window. It is probably unethical in some regards to, you can't put a patient, let's say, on a terrible standard American diet, see if they get worse, for example. Well, that's not a trial you could possibly do. You cannot put them on something like high oxalate diet to see if that worsens the disease. Same thing. You wouldn't get that past any ethics board. So a lot of the dietary recommendations that hopefully will come out eventually will have to rely on clinical studies that are not drug studies.
So just 4 minutes left, and Angela is already here. Two questions I wanted to very quickly. One is there a difference between plant protein and animal protein in this condition?
Yeah, good question. So in PKD, there is not really good evidence that protein makes any difference. So there have been clinical studies, and they essentially found that the protein intake does not associate with progression of the disease. It hasn't been quite teased apart yet whether there is a difference between animal and plant protein. That's something we're very interested in. Of course, animal proteins are more acidifying, may raise the risk for kidney stones, which we think that's a bad thing. Essentially, as a to be on the cautionary side, the dietary program we've set up together with really terrific renal dietitians, and that's a program called Renew for renal nutrition. That's already out there, and have over 200 people with PKD have gone through it. This is a ketogenic diet program that is a little bit more plant focused. So it's not vegan or vegetarian. There's still animal protein in there, but it is cutting down a little bit on the animal protein in favor of more plant protein. I don't feel really strongly about it because they're just not good clinical studies that say for sure animal versus plant makes any difference. But I think it puts nephrologists a little bit more at ease if they know their patient is not doing a carnivore, like a pure carnivore diet, for example, which makes them freak out for sure.
Just 2 minutes left. What is this Ketocitra? Please tell me in 1 minute, 2 minutes.
Yes, yeah, Ketocitra is what's called a medical food. So it's not a drug, not a supplement, but there's another FDA-regulated category called medical foods in the US. It contains the exogenous ketone beta-hydroxybutyrate together with citrate, just essentially citric acid. The BHB supports ketogenic metabolic therapy. And the citrate actually supports the suppression of these microcrystals that I've mentioned that can actually worsen the progression of polycystic kidney disease. So it's formulated in a kidney-safe way. You know, it's sodium-free, of course, sugar-free, and you know, there are no fillers or anything like that that could harm kidney function. And it's been on the market for a couple of years already. I would say it has helped a lot of people with PKD, and you know, that's the subject of these clinical trials that we're doing.
So I do have one client who has recently come in. He's from US, and I think he's from NJ, and I have recommended him to get Ketocitra. He's a CKD patient. I mean, not CKD exactly. Creatinine is just around 2.2, 2.3. He has blood pressure, diabetes. I thought this would be an additional intervention for him to help. I have read about this in your website. I recommend. Hopefully, he'll get back. You know, I told him that this could be beneficial addition to the moderate ketogenic diet which is going to follow. So, Professor Thomas, thank you very much for insightful discussion. I think this discussion today gives a hope to India that PKD can be resolved with ketogenic diet and with possible these supplementations which we produce also. So thank you very much. Thank you very much for insightful discussion, and we hope to have you again back to have a little bit more discussion on this. Thank you very much.
Excellent. Thank you so much. Bye-bye.
Bye-bye. See you.